All right, so thank you all for being here today. It's really an honor to put together such a great conference and hear so many great speakers. I want to tell you today about the Global Health Impact Project. The Global Health Impact Organization aspires to advance access to essential medicines by evaluating and comparing their global health impacts. So some of you have heard about the project either at NPR, through the Wall Street Journal, through our own pipeline, Go Pipeline, or obviously at today's conference. And what I'm going to tell you about is version 1.0 of the model. So we have a website, you can go to it and check it out with the global-health-impact.org if you want to see what's available so far. But we're going to talk today about what this model is and what we might be able to do with it a little bit. And then tomorrow there'll be a workshop on the Global Health Impact Project, so you can all come and talk about global health and how to actually make an impact or a greater impact with us. So I'm really excited about it. Okay, before I tell you about the index, I want to tell you a personal story about why I became interested in working on this project. So while I was writing my dissertation, I spent some time doing research with the Philippine Community Organizers Society. And they took me to visit a woman who I'll call Tamil, who was living in Smoky Mountain. Smoky Mountain is one of the world's most infamous garbage dumps, and her children survived by picking up garbage and selling it to the recyclers. So it was really striking to see how this person was living in light of the fact that about half the world's population, like her, 2.5 billion people, live on the equivalent of what $2 a day buys in the US. So many of the global poor obviously suffer terribly from this. They can't access clean water, decent sanitation, adequate food, shelter, education, or basic medical care. And as a result, 18 billion people suffer and die young from easily preventable poverty-related illnesses. So if you care about world poverty, then obviously I think you need to care about global health. And that's how I became interested in global health in general. I also work a little bit on human rights. So the UN Committee on Economic, Social, and Cultural Rights states that health is a fundamental human right, indispensable for the exercise of other human rights. Every human being is entitled to the enjoyment of the highest attainable standard of health conducive to living a life with dignity. People need access to health services, sufficient food that is nutritionally adequate and safe, basic shelter, education, sanitation, safe and potable water, and essential drugs. I believe we have reason to think creatively about how to fulfill this human right. So focusing on the access to medicines problem in particular, I came up with the idea for a rating system that might allow us to make some progress in doing so. The key idea was this: a broad and accurate picture of what we've achieved in helping people access essential medicines is important for guiding national and international organizations' efforts. There are many indicators for measuring global health need. The Global Burden of Disease Project has, over the past 20 years, provided a good estimate of the death and disability that's due to different diseases around the world. There's also many other measures. But I found there was similarly no comprehensive effort to evaluate essential medicine's impacts on improving global health. So the Global Health Impact Model, supported by a collaboration of researchers from universities and civil society organizations around the world, attempts to measure pharmaceutical products' impacts on global health. And the aim is to advance access to affordable medicines with this data. And what I want to do is tell you about the science behind the project today, and we'll talk more about the policy stuff tomorrow. But what we're doing is we're estimating the impact of a drug for a disease in a country by subtracting the death and disability from a disease when it's treated from the death and disability from a disease when it's untreated. So basically, if there was no treatment in the world for something like HIV, there'd be a lot of death. And then, sometimes there's remaining death, but whatever is not remaining is the impact, roughly, of treatment. Okay, very roughly. And so the drug's impact then is just the impact of the disease when it's untreated minus the impact of the disease when it's treated. So how do we do this? What kind of data do we need to do this? I'll explain this more carefully in a minute. But basically, untreated counterfactual death and disability is what we have to figure out. What would happen if nobody had HIV medication or malaria medication or TB medicine? And we do this with estimates of the actual death and disability, the incidence of the disease, patient treatment coverage, and treatment effectiveness data. And we use data on effectiveness where either from clinical trials, which we just talked about, or observed effectiveness where that's known. So if we can get better estimates, we definitely use those. What I want to do then is walk you through this model just in a bit more detail and then describe some of its limitations and advantages, and then we can figure out what to do with it later. So I hope I can explain this. So the whole big box there, let's call that the mortality and morbidity in the absence of treatment. It's basically what would happen without treatment, the death and disability. Okay. And part of that, as I said, is remaining. That's the global burden of disease that still remains in the world. That's how many people are dying and suffering from those diseases. And part of that is alleviated by treatment. And what we're trying to do is extract out that part. Okay. So what we have is information on the number of people who need treatment. That's the big bracket. The number who are actually receiving treatment, and the number who are receiving effective treatment. We have effectiveness, so we can get the number receiving effective treatment. And we know that the disease burden, the suffering that's still around, is coming from people who are either untreated or ineffectively treated, right? Roughly. And so then that's that length of the top, that's the length of the top box, right? And we have the information on how much global burden disease there is. There's all those people measuring the death and disability from the disease, right? So if we have the length and the area, then we can get the width of the box. And the width of the box is just the average impact of an untreated or ineffectively treated case. Once we know that, we know how many people are effectively treated, right? So the average impact of an untreated or ineffectively case times the number of people who are effectively treated gives us an estimate of impact, because that's what's alleviated by impact. So roughly at a very high conceptual level, that's kind of what we're doing. And this is version 1.0 of the model. Before it was, as it is on the website, it's explained this way, and it's a little bit simpler, so it's not quite right, but it'll give you an idea. Suppose there are 100 people dying in some country of the world in some year, and 50% of the people who need a drug for that disease have access to it. Then if it was perfect, right, it might save 50 lives. But they're never perfect, so we've got to take into account the effectiveness of the medication. If it's only 80% effective, then you'd estimate it saves 40 lives. That's a little simpler version of what's actually kind of up there. Of course, it's all much more complicated than anything I've said. We have been collecting data for 6 years, this huge database of information. We have to look at disease models, so we have information on TB and drugs susceptible TB, and we look at MDR and XDR TB, different patient groups, people who have HIV and people who don't separately. And we have to do some resistance, use some resistance data to model out what percentage of people ought to be receiving treatment with different drugs and different regimens given treatment guidelines. So I'm not going to bore you anymore with the science of it, but I just want to say we've really got the scientific model of impact, and what the end result is, estimated death and disability that's alleviated by treatment around the world in all these countries. And I'll show you now some of those pictures in a minute. Okay, I think I already said that we do this separately for different kinds of TB and different patient groups. We also look at all the first and second line regimens for HIV, and we look at the 5 main ACTs for the most common kind of malaria. And we're working to expand this a bit. And then at the end of the day, you get these nice pictures on the website with these graphs that show you the impact of the various drugs. Okay, so this is just for TB here. And what you're seeing on I guess your left-hand side is each impact out of the total impact. So we treat drugs within the regimen equally, and there's 4 main drugs for TB, and so you see that those 4 drugs are having a large impact, or obviously equal here because we treat them equally within the regimen. And then if you just look at the graph on the right, that's a lot more interesting, I think, because you see 75% of the burden of this disease still remains, right? We're only alleviating 25%, and then you see the impacts of the drugs there. You can see it for all the diseases. Okay, so what do we do with this information? Well, one of the things is we have individual scores in countries, but another thing is that we can take that and add it up by drug, or take the drug impact scores and see what companies hold the patents on the most impactful drugs, and that's what we've done. So here all you're seeing are the patent holders, drugs, impact scores, and Sanofi has the patents on some key anti-malarial medicines and some TB medicines, and they're color-coded, so you can kind of get a sense of what's going on there. I should just say this company index, it's simply measuring the impact of the drugs. It's just showing this a different way. So we're not meaning to suggest that a high-ranking company is a socially responsible one. The index has to be read along with other sources to get a complete picture of a company's impacts and practices. But we think it was interesting to provide this because it provides a potential mechanism for incentivizing companies to promote global health. Because companies' drugs will have a greater impact insofar as they, one, address larger problems, two, do so more effectively, or three, become more accessible. Because that's the data that we rely on. There's a lot of limitations here, so I will happily discuss some of them in question. I'll just highlight a few for you, many more. One thing is that we don't account for the fact that reducing the number carrying the disease also reduces the number of new infections. Obviously, these are infectious diseases, and we only capture part of the impact of the medications. We also don't consider the impact of accompanying diagnostics and therapies. And for malaria, this is a big deal, and we're trying to fix this, but that's one of the things we want to work on. And there are many important limitations to the quality of the data we use. So when you only have clinical trial results as estimates of efficacy, and there's problems with that, that's your best estimate of effectiveness, and we end up using that data, and we want to improve that as well, but it's very difficult given what is out there. So our analysis finally doesn't capture the full volume of each product used in each country. So sometimes with HIV medicines, we know pretty well globally what people are getting, what regimens. But in other cases, we have to use treatment guidelines and some evidence, other evidence to try to figure out what people are getting. Okay. And then again, you can see the impacts here for all three of the drugs together. 63, three of the diseases we're working on together. 63% of the burden is unmet for malaria, TB, and HIV, and the rest of it is alleviated by drugs with the patent holders here. The advantages of the model are that it's very simple. We try to make it transparent. You can learn all about it if you go to our website. And we use a simple methodology that's comparable across all three diseases. We think it's the first scientifically rigorous comparison of the impacts of drugs on death and disability in this way. And so it's very different from the indexes that are out there, like the Access to Medicines Index, which looks at mostly at company policies, right? Do they have good patenting policies and licensing things and so forth? We think a scientific model of impact is a neglected yet important piece of a larger picture. And the index provides a lot of potentially useful information. So here you see the impacts of the drugs on each of the three diseases. We just aggregate the drug impact scores by disease. And it's interesting that despite the very different funding situations, the impact the model suggests we're having on each of the diseases is similar. We also make a lot of the data that goes into the model available in what I hope is a simple and illuminating way as well. So here you see the DALI information. That's the need for the drugs, the death and disability in each country in the world that we use from the Global Burden of Disease Project. This is some data on treatment effectiveness by TB type, so it's highly aggregated data that we're using. And here you see data on treatment coverage for malaria by drug. These are really based on the treatment protocols. So, good data on global health impact is important for evaluating performance, setting targets, and guiding the distribution of resources. The global health impact model shows which drugs are alleviating the largest amount of death and disability in each country in the world, where great needs remain unmet, and to what extent this is due to lack of access. Because of how it's constructed, the index provides a mechanism for incentivizing positive change. And tomorrow, again, we're going to have this workshop to discuss potential uses for the index. We'll also hope to have one in Georgetown in the coming year. But what I'll do today is raise the questions that will focus our discussion tomorrow, and hopefully we'll start that a little bit right now. So one of the things we're working on is to figure out whether the index can be used to assist policymakers in prioritizing funding across countries, diseases, or interventions. So I was at the Global Fund earlier this summer. They have a metric of the lives saved with their interventions. They were interested in this model for that purpose. And they ended up using a different model, though actually the TB one is quite similar to what we have. And then they use that in their distribution of aid to countries. They use that data. So it might, in that way, be an example. Can the model guide the distribution of health resources between or within countries? Can we use the global health impact model to evaluate international institutions or country-level contributions to global health? Why has the burden of disease attracted so much attention while the alleviation has captured so little? Can we use the model to incentivize pharmaceutical companies to have a greater global health impact? Can the global health impact model help improve global health governance? In what other ways can it promote access to essential medicines and global health impacts? And should we expand the model in any particular direction to promote global health? For example, across generic firms or other parts of the pharmaceutical supply chain, across time, or across diseases? Consider for a moment just the question of why the burden of disease or the need for the drugs has captured so much attention while the alleviation has gotten so little. What you see, again, on your left here are the disability-adjusted life years lost to the disease. This is for TB. And on the right, you see the burden alleviated by the TB drugs. Now, they're really similar in these two cases, right? But there are some differences. So if you're in Mexico or Peru, then you can ask, why are drugs not having as great an impact as in Brazil, given that the need is similar? Or if you're in Niger, perhaps you could point out that drugs are having a great impact in your country, a greater impact in your country than in Algeria or Mali, you know, similar in the region and similar in terms of need. Or consider the need versus impact graphs for HIV. What this seems to say is that globally, we're really feeling spectacularally to address the HIV impact. So the red and the yellow, the red is high impact and high need, the yellow is, you know, medium impact, medium need, depending what you're talking about. The left graph, again, is the need, and the right graph being impact, and blue is low, okay? So you see we're having huge amounts of need, right, in the left-hand graph, but not so much in terms of impact. So what's going wrong? Maybe we need to focus on places where we're having an impact, or we're not having an impact, or what can we do differently? In any case, I would value your thoughts on potential policy uses for the model, as well as its construction today and at the workshop tomorrow. And I hope that some of the information will be useful to you. For example, I'm looking at where we still need to have a larger impact and where we're having some success. Good data on global health impact is as important to allocating global health resources as diagnostic tests are for identifying and treating disease. Evaluating and comparing key medicines' global health impacts can help guide decision-making, update priorities, and ensure accountability. I hope our model can advance global access to essential medicines and ensure the human right to health for all, or help, so millions of lives hang in the balance. Thank you very much.
Thank you, Nicole. Thank you, Nicole. So the floor is now open for questions.
Hi, I'm Peter, Public Citizen. Thanks very much for the excellent presentation. I guess one thing I'm wondering about, I think about this in this context and other models that I see, is that health system resources are finite. And so to me, an access calculation is not only about access to a particular drug, but actually the cost burden that that particular drug imposes on a health system in its entirety, and the opportunity cost of providing full access to that drug, and whether that negatively affects the ability of the health system to provide treatment or prevention services in other areas. So, you know, for example, if we looked at the Gilead hepatitis C drugs right now, a model like this would very significant impact on the disease burden, but we're also having to ration care to those drugs due to the high cost, and agencies are being pushed to make very tough decisions about what other services they're going to provide or not in order to provide access to this exceptional drug. So I wonder if you can address that a bit, if you see, you know, possibilities there.
Yeah, no, I absolutely agree. I mean, what I'm concerned about philosophically is the impetus to ration. I think what we should be focusing on is ensuring access to essential medicines for all. And so one of the things you can see is in this model is some places with some drugs we're not having an impact where we should be. And sometimes the barrier is price, right? And it's pretty obvious. I mean, you could do regressions to prove it, but you'll see that drugs that are higher priced are less accessible. You might be able to prove it, I don't know. In any case, in those cases, if you can decrease the price, right, you might be able to extend access more broadly and get people using better regimens and so forth. So I'm hoping that this can be an argument for getting more resources or for lowering prices or for making drugs more accessible, not an argument for shifting resources within a constrained budget, although in some cases maybe it's important to shift them and you might be able to also use it in some way to do that. You say, look, this is very expensive, we're having an impact with it, but you could have twice as much impact over here if you shifted it. I would hope that we can meet everyone's basic health needs. So. I don't know if that answered your question. Happy to come back, yeah. Don't be shy, I'm really actually, well, I'm not sure I'm actually nice, but I'd happily answer your questions, so thank you.
You touched a lot on the impact of the pharmaceutical industry and cost and things like that, but I was also wondering if you at all research, especially like cultural impact. I noticed, for example, in Russia with tuberculosis, I know there's a high incidence of tuberculosis in the prison population. Mm-hmm. So I'm wondering if there's any impact, if there's any kind of indication as to why it's not as well treated there, if it has something to do with not wanting to treat the prison population or...
Yeah, no, that's good. There are some people here at Binghamton who do work on culture and health. I think it's really important, really interesting work, especially in medical anthropology. And I think that, sometimes the problems are cultural, right? So it's not price, it's something else. People are not treating prisoners with due respect and respecting their human rights. And so you can see that sometimes in the data, maybe here in HIV in Russia, or the former Soviet Union, we're also having very little impact on that disease, and it might be associated with the same kind of problem. So, the index opens the door to all kinds of empirical and academic research on what are the causes of the fact that we're having less impact, right? As well as what are the consequences of it. Maybe a lot of the causal stuff was already able to do. You're already able to do it, but if you're having a great impact or not, what are the consequences of that for conflict, for society, for development, for cultural change? And those things are, I think, things we can start to explore a little bit more as a result of this. Though personally, I haven't written on the cultural aspects of health. Thank you. Back.
Hi, I'm Aidan Hollis. I'm just wondering, Nicole, if you'd like to comment on how you think about cases where there might be a conflict between apparent behavior by companies and actual outcomes. So, for example, if a company had really great success in this measure, where it was actually having a lot of impact on people's health, but on the other hand, in terms of its sort of assessed behavior, maybe ethically it didn't record all the trials, or something else wasn't perfect in that way. How should we think about a conflict between those, between behavior and outcomes?
Yeah, no, that's a really interesting question and something I need to think more about. But I think that we need a larger picture, right? So we need to know where we're having actual impact with the medications, where we're not. But we also need to know where the policies, if we're talking about companies, where the policy's good, where are they not good. I think that's really important. I think that there's got to be a causal relationship between good policy and good outcome. It's not always perfect, right? You can have good policies that don't have good outcomes. You can have bad policies that do, or companies with bad policies that do have good outcomes. And so it's opening up the opportunity to take to question that. So if we took the Access Medicines Index evaluation of companies' policies very seriously, and then we look at the impact, we could kind of look for the correlations between them. What policies really do make a difference? In certain respects, our index was really highly correlated with the Access to Medicine's first version. Their index, it was 2010, and things have evolved, and there's certain ways in which the policies still, just looking at it, seem to have an effect, but we'd probably have to do, serious empirical research to see how do these policies actually impact global health? What kind of impact do they have on lives saved? Because I take it, it's not our only objective, but one of our main objectives is really to help people live better lives, help them survive, avoid preventable death and disability from terrible poverty-related causes, and this is what we're trying to measure the success in doing that. Thanks.
Your talk was very, very interesting, particularly from a pharmacy standpoint. My question has to do with philanthropy. We know that Bill Gates wants to wipe out malaria, and Warren Buffett's joined in on this. Do you have any measures of whether this type of philanthropy, big philanthropy, will make an impact on medication distribution, impact of the medications themselves? Do you have any data on that?
Well, I think that this opens the door to that kind of thing. So a couple answers. So one is, if we can get this updated over time, then you could look at, well, as these players come in, what kind of, and look at their policies and see, what kinds of things are actually making a big health impact indirectly through economic research. Another kind of thing you could do would be to try to figure out what proportions of the global burden of disease alleviated by drugs are being alleviated by drugs coming from, say, Gates or the PEPFAR, or it could be anything. And I think we're starting down the road to being able to do that. So we're trying to look at more of the pharmaceutical supply chain and the drug distribution data through the WHO. And I think I can probably get data from PEPFAR. So it might be possible to say, break that out, which distributions are coming from which organizations. But we're not there quite yet in terms of that. Yeah.
Is this on? Yes, I'm sorry. I may have missed it, but is there any way of involving the parameter of the ability of the local caregivers in dealing with disease to measure the effectiveness of the level of or the abilities of the caregivers in a particular population?
Yeah, I don't have anything on that, I'm afraid. However, I think it's a really important question, because obviously drug impact requires good health systems in place and all these social determinants of health. So how do you figure out, the Global Fund actually has this problem in a serious way, where they want to claim a certain number of lives saved, and then they have to figure out, well, how much is our contribution versus country level health system contribution versus other things. And I don't know if they have measures of that. I don't think so, but I think it's something that people should be thinking about. Thank you. I'm not sure you can actually get a good answer either. I mean, it's a hard question.
Hi, thank you for your talk. My question is about the potential for incentivizing pharmaceutical companies with the index. So I'm wondering, does the index incentivize them to create more effective drugs for the diseases that you're focusing on? Or does it only do that, or does it also incentivize companies to effectively deliver and create and promote what are currently the most effective drugs, even if they didn't create it? Or both?
No, absolutely. So the incentive, that it creates is, I think, well, I hope it's the right one, it's to do whatever is necessary to have an impact. So if that requires investing in health systems and infrastructure, it creates that incentive. Whatever increases the access to effective drugs for the greatest needs is going to get the greatest score. So holding everything else fixed, more accessibility, equal amount of need and access, then you get more impact. More effectiveness, so new drugs that maybe might more effective for the same disease, more impact. And if you address greater health problems with equally effective drugs that are equally accessible, again, greater impact. So that is, it's a market-based mechanism, right? Companies could do everything right and fail. At the same time, hopefully those good policies will have an impact. That's what we hope. And then it creates incentives for all kinds of partnership, public-private partnership, direct investments, increasing access in various ways, and whatever are the most effective ways, I think. I should also say, while we're waiting for another question, that this is almost an entirely student-driven thing. So I want to just thank the GHI team and all the collaborators for their help. They do all this hard work. They do it all for free. This conference was entirely organized by them. And so can we offer them just quickly a little round of applause? Thank you.
Okay, so your answer to Jen just made me think, so if you're interested in global health impact, so suppose you could show that building schools and building roads had great health impact, and then somebody would say, well, why can't we be measured? Why can't you make incentives? Because right now we don't have any incentive to build these schools and to build these roads. Now, if we were measured in such a thing, we'd have great incentives. So is there a reason why it's focused on pharma companies and drugs, if that is only one part of the problem?
Good. I mean, the initial idea, I wrote a policy paper 6 or 7 years ago, was like, can we just measure global health impact, right? By anything, any corporation, any policy, anything. And I think as long as it's done in terms of, how much life is saved and death and disability is alleviated, conceptually, you could fit it in under this model. I mean, we started with some of the worst global health problems in terms of lives lost on death and disability to these diseases. We're going to expand across diseases and interventions, and maybe I could see first something like bed nets coming on board as like an evaluation. But it's not impossible that you could have this index or a similar index where you look at the impacts of policies, impacts of roads, impacts of whatever. I think it's quite important and fully encourage global health impacts. So, thank you.
I just also had a quick question about like whether you controlled for adjunct therapies, especially with these drugs, and especially in places like Africa where there are a lot of adjunct therapies, especially that go along with like AIDS treatment and things like that, and whether or not there might have been an impact of those treatments as well.
Good. I mean, so we just started really small. This is it's our birthday party in the sense of the birth, the first year. We just launched the World Health Organization, this very beta
therapies
for a model for 3 diseases. We don't have major funding. We've gone entirely off of university-funded research and student volunteer efforts, and so the progress at which we can do this kind of thing is really slow. But I do think that the possibility of including drugs for associated infections, cancer, even other kinds of diseases, all this stuff is something that would very well fit within the ambit of the project. So we're working next, I think, on neglected tropical diseases, but hopefully also over time in other ways, expanding and refining our models. Thank you.
There's still plenty of time for questions.
We can also go, if people we're going to have a whole workshop on this, so if people don't have questions now, you can think about it. I mean, I am curious if anyone has thoughts on, if I can figure out how to go back. Students made this, by the way, so I don't really know how to use it. But how do we do you guys have any thoughts on any of these things? Does it seem like a plausible way to go forward with this? We'll talk about it more tomorrow, but there are questions for reflection if anyone has some thoughts on those. On the back.
Hi, Nicole. So you were saying that your organization, you do a lot of research with students. I was just wondering what benefit you derive from involving undergraduate students and graduate students in your organization.
I think it's really amazing. Jean, for instance, has been volunteering with us for this semester, and she's a great capacity to write brilliantly. And so we've had her doing all kinds of research for the project, finding data, but also doing some writing. The students do all the social media stuff. I couldn't tweet. I did tweet actually twice. I didn't even know how to say tweet until recently. So students are doing all these amazing things, and I'm just inspired by their energy, their creativity. They're going to create a blog. The class that we're running on the Global Health Impact Project has also got some really amazing projects coming out of it. So I find it to be an inspiration to work with young people and to get their ideas. And I work with them kind of like equals. So John Chow in the back, and Nicole, they're going to be moderating and presenting tomorrow with their PhD students, and just to watch them learn how to do this research and how to organize conference and moderate and present for the first time, it takes you back. It's really exciting. So
I was just wondering if either there been or will there be conversations with those companies that are very low on the ranking and getting feedback from them and what they have to say about it. I mean, that could be potentially interesting to get their side of the story on that.
Yeah, we haven't really had a lot of conversations with companies up to this point. I think it came to everyone as a surprise when people were asking them questions, and we got feedback through NPR or whatever that article was. It's pretty much been academic enterprise to really measure health impact. And now we're moving into, let's have some discussions about policy and start to talk at least with, a few of the companies on the workshop. We'll hear from them today. And then I guess it is an interesting question. I think I don't really know how to approach it, but I think it's an interesting thing to have those conversations and see what people are thinking about it. But Aiden has something on this. He's also a Global Health Impact co-author, so we should let him talk about this, please. Thank you.
Just a comment on that and the idea of shaming with this index. The structure of the index is that it only measures companies' contribution to these particular diseases. So if a company has a fantastic impact on cancer, it's not going to be captured here. So shaming is really out of the question.
No, absolutely.
And companies that could be 0 on the index, and it doesn't mean anything bad about them. It's just the nature of the index. So, the reason for thinking that these 3 diseases are particularly interesting and should be valued in some way is because they're diseases that are, to some extent, undervalued by the profit measure. So these are diseases that really deserve to be captured in some way. And companies should be highlighted for a real contribution and should be recognized for it because it's not necessarily the most profitable area to be developing drugs for.